Yes, Meg, man, you're first. Good afternoon, everyone. Tonight we're going to talk about the hip. We're going to talk about what the heck is going on. Why am I having pain in the hip? So that's what our focus is going to be tonight, as well as if you guys want to go ahead and communicate with one another, maybe get some love from here and there. You guys can also do that while we're actually hopefully going on to a decent topic, and maybe we'll go over some treatments. We might go ahead and deviate a little bit depending on what you all want to talk about in regards to maybe the hip or the leg or the lower back tailbone area. If maybe you or a loved one is having some issues, we can go ahead and go over that too. Let me just hop on here so I can see your guys' discussion. Miss Angels, how you doing? Yeah, Megan's had that pain before, so I'm going to bring my phone over here so I can see some discussion. So, going on to the topic, like one of my first main videos that did very well was actually one, probably like cliche would say, I never expected to do well. It was actually hip and snapping hip. Apparently, everybody has this problem. I wouldn't say everybody, but at least I think 600 or 700 of my views so far. I think it's my highest gross views. Is that particular video, and it's basically on snapping hip syndrome. So we're going to go over that. We're going to go over osteoarthritis. We're going to go over impingement. We're going to go over probably what I call avascular necrosis. That's basically where the ball dies because it loses its blood flow. And if there's anything else that you guys want to go over, that's also, bring the questions on. Since obviously I can't do it on Saturday because that is a pre-recorded video, I try and do it at least tonight to maybe answer some questions from last week's video, or we're also going to talk about my next Saturday's video. And if you guys have any questions on that and what you would like me to maybe add to that. So, hi, Harry. Honey and Josh, you made it. Thank you, honey. Now, Megman, you said you've had that pain before. So let's go ahead and just talk about the basics of the hip. So we'll stick with Big Bertha here for a second. So I'm going to go ahead and dislocate this hip here. So we have the basic ball, and you have the, sorry about that, folks. And you have the basic socket. Now, that ball and socket has a huge ligament that runs around it and kind of like in the neck. It's what is called the Y ligament or the bigelow ligament. And so that is a huge ligament that wraps around. It twists and turns, because when things have a lot of cross kind of members to them, it makes the tensile strength of that particular structure, in this case ligament, excuse me, much stronger. That's right. Go ahead and connect if you want to, folks. I'm hoping I'm going to get some more people in here. I started like 10, 20 seconds earlier, but it's after 6:30 Eastern Standard Time. But when we look at the actual socket itself, it has cartilage in the inside of that socket as well as on the ball. And when that part wears over time, whether you've stepped off of a particular, let's say you were a forklift driver and you stepped off of that forklift the same way every single time, you'll wear a certain part of that cartilage off, and unfortunately at some point it becomes arthritic, which essentially means that the ball or the socket in this case has lost that thin layer, and it's starting to go into that bone area, and you're getting what people have heard in the past called bone on bone. Any questions so far, folks? We doing good? Hi, Larry. Now, there are a lot of problems that can happen as we grow when it comes to the ball and socket. Now, I'm going to show the video on Saturday this week coming, and I'm kind of going over the things that you don't and the things that you do when it comes to the hip and arthritis. As we are growing, we want to make sure we're staying out of what we call W sitting, where your feet are behind you, your knees are in front of you, and you're kind of sitting down. Because what happens is, as we age, that ball becomes deeper. That ball, when we're young, it's very shallow. And so as we grow and as we put equal weight through the ball, through your leg, that socket gets deeper. And so you get a nice, round, deep socket that fits the entire ball. And if you sit incorrectly as a young child and you're consistently staying that way, or what they say nowadays, crisscross applesauce, myself growing up was called Indian sitting. Anyways, it can cause the socket itself to be what we call malformed or deformed, and that you don't have a nice union between the socket and the ball. Yes, thanks, Steve. Thank you so much. Thumb up for the host. I always forget that. I don't know why I do, but I forget that all the time. I probably shouldn't. But thank you so much to Lifestyles. Lifestyles of the Rich and Famous. You got Harry here giving me a little love. Harry says I'm doing great, or he's doing great. So that's the big thing. So if you have a child or a baby, making sure that they're staying out of the crisscross sitting or the W sitting, because over time that will affect how the ball sits in to the socket. You can have a lot of problems getting older. So words to the wise for that. So the osteoarthritis is where part of the cartilage is either worn on the inside of the socket or the ball. Just like the shoulder has a labrum, the ball itself also the socket also has a labrum. It's the outer edge of the socket. And what it does is it allows the socket to be that much deeper. And so the ball has something really snug to hold on to. Now that's where we start to get problems, because as we age, that labrum, just like in your shoulder, in your hip, can cause a tear. You can have what's called a labral tear in your hip. Now, there are 3 kinds of snapping of the hip. You can have a snapping hip of what we call the iliopsoas. The iliopsoas is 2 muscles. The first one here, the psoas, comes all the way down along both sides of your spinal column. It comes in to the ilius area. There's another muscle inside here. Those 2 muscles join together to become one main tendon, and that is your major hip muscle that makes your hip go up and down like that. So it runs down underneath your groin and attaches on the back side of your hip. It also helps with rotation too. Now, that thing gets inflamed or irritated and you start doing a lot of this, what can happen is that tendon that runs all the way down and around can start to snap on some of the bones here. These little protuberances that we have where other muscles attached to and come down can snap on that, especially if you move your leg in a certain way, and it's called snapping syndrome, or snapping syndrome. Now, particularly, it's not a problem unless you get the thing inflamed. If you do that repeatedly every day, you can go ahead and start getting referral pain down in the inside or across where the muscle belly goes across the spine or inside the hip, and get some of the other structures around the hip inflamed as well. The other type of snapping hip you can have comes from, I'm going to put this thing back together just for a second, or partially back together. It's called your iliotibial band. And that is a thick fibrous tissue, and it runs the side of your hip. Okay, and runs all the way down and attaches across the knee joint. That thick fibrous tissue has two main muscles on it. One across the front called your tensor fasciae lata. There's a $50 question for you. All right, or TFL for short. And the glute muscle on the other side. All right, and they kind of a V pattern. And if they get irritated, they can also refer pain down to that IT band. Well, that IT band can get inflamed and cause some clicking across any of these bony structures too. And so you could have some iliotibial band or some clicking coming from that. And if it's bad enough, it can vibrate and you can actually hear it. Hi, X-Ray Lady. Thanks for coming by. Tonight I'm talking about osteoarthritis and some other stuff in the hip. We just got done talking a little bit about what happens with the arthritis of the ball in the socket. We just started talking about snapping syndrome. And at the top of the hour, or half hour, I should say, we initially talked about that the most views that I've had so far on my channel has actually been snapping hip syndrome. So when it comes to this snapping hip syndrome, as long as I was saying before, as long as you don't strum it like a guitar string all the time, it can click and you're fine. Most people think the worst thing when they have hip pain, the first thing they think is labral tear. That might not be the case. Well, you might have a labral tear, but it might be what we call asymptomatic, means that you're not having any symptoms caused by that tear. Now, if this doesn't seem to go away, you have conservative physical therapy, come and see someone like me, and it doesn't get any better, the doctor might go and do an MRI. And for the labral tear of the hip, the gold standard, which basically means that for research to show the best possible result for a labral tear of the hip, is you need to have a contrast. So you have to have that dye injected to really light up that labrum, which probably X-ray girl would know all about. And then they do the MRI, and then they can actually see that tear in the actual labrum of the what we call the acetabulum. Now, that being said, before they even do that, they might the orthopedic doctor might go ahead and just do an injection in the hip, in the front, or they might go to the side. The side, you're thinking maybe it's an iliotibial band syndrome issue. They might go in the front here because they might think it's the iliopsoas snapping. So if that seems to help your symptoms, it can kind of give them an idea if they truly even need to spend all that money to do an MRI in the first place. So we take a good old hip. Now the guy's got a dislocated hip. Back in the day, there was a guy by the name of Bo Jackson. All right, this is probably, I don't know, 25 years ago. Bo Knows was the commercial. Bo knows this and Bo knows that. But Bo Jackson had what's called avascular necrosis. He had in both his hips, I think. He played professional baseball and he played professional football. The crazy guy at the same time. That's how skilled the man is, or was. Still alive, but obviously he's the ripe old age. He's probably in his 50s now at this point. He had 2 hip replacements. And back when they used to do hip replacements, let's say 10, 15 years ago, they used to only expect the life expectancy of a hip replacement maybe 10 years for normal wear before it breaks down, the plastic, the metal, and they have to replace it, or what they call a revision. Nowadays, with better technology, when it comes to the material that the replacement's made out of, it can last 20, 25 years from what I'm told. So you're getting a lot more younger people being able to receive the hip replacement instead of suffering as time goes on. And so an avascular necrosis means essentially the blood flow, literally where this little string is where that blood flow goes to, right to the socket. And if for some reason you have an accident, it gets sheared, or you have some sort of malformation when you were young and it didn't, and it causes a tear and that blood flow is lost, his head's going to die. His head's going to die, it's going to fracture, and then you're in real trouble. So you're going to have a lot of pain when this thing dies in the first place. You're going to be seeing a doctor. You're not going to be able to put weight through it. That's right. See, Larry 5200, he knows. He knows when it comes to Bo. Larry knows Bo. Bo knows Larry, maybe. I don't know. Anyways, and so this blood flow gets lost, and then boom, you're going to need a replacement. There's no fixing it. Needless to say, when they do the replacement, cut it right off, drill down into the shaft, in this case the femur bone. They go ahead and put a new neck and stem and head on the end of it. They put a surface within the socket itself. They put you back together, and off you go. Now, when I first started as a physical therapist 20-some years ago, you're in the hospital probably a week, I think I remember seeing most people. Some people left. We were excited when they left 4 or 5 days. We thought they were amazing. Nowadays, you're in and out in a day or two at the most. I mean, if you're there 3 days, they're looking at you like, hey, what you still doing here? Oh, we only got 2. Everybody left. Oh, all right, that's all right. We're going to keep going. You know why? Because I love you. You love me. Knowledge is power. And hopefully we'll have some more people come in as time goes on. We'll see. Anyways, so there are 2 types of hip replacements that I know about. There's a third one that I'm going to speculate about, but I haven't read any research on it at all. Okay. The first one that you see hip replacements is called a posterior lateral replacement. All that means, posterior is the back side and lateral means the side of the hip. What they do is they go in there, they try and split the muscle fibers as much as possible. They're not cutting through the muscle bellies. They try and spread and open them up, get to the bone. They have to dislocate the hip, obviously, to get the head out and then go from there. Now, what's that do? That causes a lot of weakness on the back side of all the muscles. This is the hip replacement surgery that they've been doing since hip replacements have been around. What that limits is you can't cross your legs, because obviously you cross your leg, your hip will dislocate. It's very weak on the back side early on. You can't turn your leg inwards because that would cause the ball to go out. Okay? And you can't go past 90 degrees of that hip movement because the ball could come out of the socket when it's that weak. Now, whether that is this way, bending forwards, or whether that's coming up. Both of it's the 90-degree angle coming from your chest to the hip area. That's the 90-degree angle. Hi, Wild Style. Thanks for coming. So that's the old approach. That's, as a physical therapist, if there's no other reason, this is the approach you should be having nowadays. Over the last probably 10, 12 years or so now, they go from the front, the anterior approach, which means is they have a machine, you're lying down flat, they have a machine that actually brings your leg out to the side like a snow angel, and it distracts the socket, the ball out of the socket, excuse me. And so all the surgery is done from the front. You have no structural integrity loss on the back side at all. That means the only restriction that you'll have post-operatively is bringing your leg back away from you. Because as you bring your leg back away from you, the head comes forwards, and that's where it's weak at this point. So if you're going to have a hip replacement, I implore you to only go to a doctor that does anterior approaches. There's plenty of doctors around that still do the posterior lateral approach. That's what they were taught in school. That's what they're going to continue doing. They're not going to go back and learn a new technique probably. Trust me, find someone who does the anterior approach. The recovery is much faster. There's only one restriction. You don't have an issue with trying to wipe your rear end or trying to tie your shoe or trying to pull your socks on or your pants. It's a game changer. I can't believe they're not all forcing people to do it that way. Now, there might be some reasons why they might not do it. If there's some sort of osteoporosis that's too bad for the distraction, or whatever reason that they might come up with. There might be some particular reasons why they can't do the anterior approach. But if we're just talking about someone that's fairly healthy, they just got wear and tear of the hip joint from beating on it for their lifetime, and they need to have it replaced, you go with the anterior approach. Words to the wise. I've done this long enough. I've seen enough surgeons. I've treated surgeons myself as a physical therapist. Once they've learned a certain technique one way, that's the way they're going to continue to do it no matter what. They're not going to go back and, now don't get me wrong, it's not all of them, but the ones that I've seen, they're going to continue to do the same approach that they've done their entire career. Michigan Outdoors, we're not dropping new videos because that's going to be considered spam. I can't do that, brother. Thank you, Phyllis Brown. Anybody that comes in and subscribes to me, I promise you, when this is all over, I will subscribe to you. I will watch the video. I will be putting a comment like I always do. I try and watch at least, if it's a 5 or 6 minute video or an 8-minute video, I try and watch 50%. If you want to go ahead and connect here, I know Phyllis Brown, Indestructible, is fairly new. You guys want to connect. There's some people that are not content creators that are here. They're here, and so if you want to connect, if they want to connect with you, but be mindful that they aren't creators. So when you go to their site, they might not have any videos. Okay, so that's the two approaches I employ you as I beat the dead horse, the anterior approach. Now, there's a newer one out there that's I don't know a lot of the data about. I need to look up it a little bit more, but I'm going to speculate. It's a minimally invasive robotic approach to doing a lateral, posterior lateral kind of side approach, where it's the robotic. Whether it's a Da Vinci or a Leonardo, whatever the robot they want to call, but basically it's a pre-programmed surgery. And then during the day of the surgery, they program it into this machine, and the machine basically does everything, all laser guided and software, 1,000 times better than the best surgeon's hands could do. And so you get a lot less trauma to the site itself, and your recovery is that much faster. Less bleeding, less cutting, always means you're going to improve much faster, less likely to get an infection, less likely to have a longer recovery and rehab. So that's the third one. I don't know a lot about it, but maybe in a future video, I'll go ahead and just do one specifically just on that actual new approach. I like to make sure I do some research. Not actually listen to people, but actually read the research articles myself. A lot of people are the educated, I learned it passively from someone else and claiming it that's their own. So we don't want to do that, especially when I want to put my name on it. I want to at least have an idea of where the heck I found that information at, and did I understand it. So that is the basics of the hip replacement itself. Like I said, they last between 20 and 25 years. 10, 15 years ago, if you weren't at least in your 60s, you weren't getting a hip replacement because the hardware wouldn't last that long. I think I've seen some younger ones now in their 40s, early 40s that are getting them when their hips are really bad. So that's pretty impressive that, they're doing hip replacements that young. I would have never thought when I first started my career that, oh, yeah, you're going to have a hip replacement when you're 40 and you're going to be able to live the rest of your life or pretty close to the rest of your life without having any issues with that. That's an undertaking, One little statistic I'll give you, because I like to do that every once in a while on my lives. For every 1 pound you're overweight, that's right, for every 1 pound you're overweight, it's 3 pounds of pressure on your ball and socket. That means if you're overweight and you're overweight by 100 pounds, that's right, that's 300 pounds of pressure on that old hip. So be mindful that, yes, this ball and socket and ligaments are very strong, but over time you wear them out. And if you still weigh a lot when you want to have a hip replacement, good luck. Some surgeons will be like, I'm not touching you until you lose some weight, which is smart, because for you to get the best possible outcome out of a hip replacement, you need to weigh less, and your hip muscles themselves need to be stronger, because they're going to be traumatized afterwards as well as before the surgery itself. So you want to be the best possible outcome. And to do that, I mean, if you weigh a lot, you might have to lose some weight. Full-time dream, thank you for coming. I got some of my RV life people coming in. Oh, that's beautiful. It must be either someone's ending or someone's coming in. I watch you guys as much as I possibly can. Sometimes it's the live, sometimes it's the videos. Sometimes I forget to comment. I'm like, oh, crow, I forgot. So I want to thank you guys all for coming. If you like the information, I would love you to hit the thumbs bell. If you don't like the information, you can hit the down thumbs bell. That at least give me an idea how well I'm doing, and I can go ahead and, if I get enough thumbs down, I know I'm doing something wrong. Is that right, Scully? He ain't talking right now. Sorry. Maybe later. Who knows? Well, I was talking about the hip. We got done with the different hip replacements, what their restrictions are. We got done with snapping hip. We got done with osteoarthritis of the hip. Let's talk about piriformis. Now, that was another video I did a while back that got a lot of views. I mean, for me, anyways. I'm not a small creator. I'm a microscopic creator at this point. That's how small it is. Anyways, who knows? Maybe it'll be like a chia pet. Put water on me, and maybe everything will grow. All right, so Scully's tired. That's right, Miss Nikki. Scully's tired. I'm thinking about upgrading Scully, but with all this crazy virus stuff going around, I'm trying to save some money just in case. Thumbs up, thumbs down to the host if you love me or if you hate me. All right, some people get what's called piriformis syndrome. Now, this sometimes is overused, kind of like what sciatica is. Sometimes that's an overused diagnosis, just like snapping hip or hip pain is overused. So let me backtrack. Before we get to the piriformis syndrome, sometimes you can get pain down that lateral IT band that I talked about, where it can snap, just like the hip flexor can cause this, what we call the snapping syndrome, or running hip, or whatever, how you want to describe it. And they'll come to me in the outpatient and they'll be like, yeah, the doctor sent me for hip pain. I got pain along my hip. And so I do all the tests, and I'm going to tell you and show you what these specific tests are. So the test to really truly see if you have a real hip problem, all right, it's called a cluster test. And this is it's a combination of 3 tests that are done. And if all of them are positive, the likelihood of the symptoms coming from the hip and not from the spine is pretty good. So the first test is called the scour sign. And that is basically where the physician or the therapist passively rotates the ball all the way around to see if you have any pain. That kind of gives you an idea if you're having some arthritis or not, or if the ball doesn't seem like it's what I call smooth as butter. That's the first sign. If you're getting pain, and usually it's when you start to bring that knee in towards the front of the body, that's where it will catch at, because that's where a lot of the arthritis happens anyways, in the ball and sockets in the front. If that doesn't hurt you, the next test we'll do is called the Faber, F-A-B-E-R, okay? That's flexion, abduction, and external rotation. We'll bring you in on that and see if that hurts. And then we'll go ahead and do what's called the fader, F-A-D-D-I-R, which is flexion, adduction, and internal rotation, and see if you have any pain right around that same area, or a restriction in there. If all three of those are smooth as butter, your pain's not coming from your hip, probably. Probably ain't got a labral tear either, especially if you have pain along the lateral side. That's when I start asking the person, when everything is negative, and they have the x-ray, I see the x-ray, and the x-ray says, it's kind of average. Oh, Miss Essence. Oh, Miss Essence in the house. Thank you for coming. It must be 1 o'clock or 2 o'clock in the morning there. Thank you for coming. That's awesome. Thank you for coming. I appreciate you all coming. And so if those three tests are negative and the hip looks like on the x-ray, it's like, yeah, you got some arthritis, but it's no more than you would typically see on someone their age. I'm starting to look at the spine, then the back, up towards this hip area, and see if the pain isn't coming from the hip into the lateral side, because you can get like this weird bruisey sensation along that lateral side of the hip, along that what we call the iliotibial band, or the IT band for short. And it's not the hip at all. Sometimes they'll diagnose it with bursitis. We'll go over that in a second too. That's a trash term that's used all the time. But now if you get that referral down that side, that's what I'm starting asking them, is it get any pain up in the back at all? Like, oh yeah, it hurts every once in a while. That's when I asked them, all right, are you sitting in a recliner chair? Do you sit a lot during the day? Because this old spine, when it starts to flex all the time from sitting incorrectly, it puts a lot of stress on the joints, the facet joint, which we talked about in the previous lives, all right? And the soft tissue around the area becomes overstressed or elongated all the time, and they can naturally refer pain down the side of your leg. And so that's when it's like, uh-oh, I need to go back, call the doctor, and hopefully get a new prescription for the back and not the hip. So I do get that. I bet you I get that once a month or once every other month, that they're diagnosed with a hip problem and it's actually coming from their spine. All right, Michigan Great Outdoors. I'll let it go once. Yes. Okay. We see that you have a video and you'll go ahead and hit them back. Please stop spamming that. Unfortunately, otherwise I'll have to put your ass in timeout. Okay? Why, thank you, Essence, for sharing me out. That is very sweet of you. So let's go back to the back that refers pain down into the hip along the lateral side of the leg. What I do then, I go ahead and start treating as the back. I'll go ahead and start going back into the stomach-based positions, because if it's all this that's going on all day long, I want to get that spine out of that position. So I either want to get them straight or slightly extended, depending on how inflamed that lower back is. And there's all types of treatments under my back playlist. If this kind of sounds like what's going on with you, like, yeah, okay, yeah, this does sound like it might be it. All right, so if you guys have any questions on that, go ahead and throw any questions out that you have in regards to what I'm talking about, and I'll answer them to the best of my abilities. And so let's talk quickly about this whole hip bursitis. And so you have these things called bursa, and the bursa are all over every tendon. You got a lot of them mainly all in the joint area, and they allow the tendons to glide over the bone. And so normally the bursa are very thin, flat tissue, but if they get inflamed, they turn into sacs. And next thing you know, you have a bursitis, or an inflamed bursa. And usually in combination, you usually have tendonitis. The tendon gets inflamed too, because that's what the roof of the bursa is the tendon. So you usually get a combination. That usually is what we call around the top of the hip here, and only there. There's nothing along the hip or the crest. Their back is fine. It could be coming from a trauma, they fall on it, or maybe they lie on that side a lot, or maybe it's a sports-related injury or a walking or running technique. Maybe they have a leg length discrepancy when one leg's longer or shorter than the other that I have to look at. That's throwing off the alignment of the hip. The doctor will do an injection in that a lot of times. It's, oops, sorry there, baby. It's a Epic RV. Which exercises are you talking about? For the back or for the IT band or the bursitis? Give me a shout out. Which one are you talking about? Ah, the bursitis. Okay, yeah. I'll get to that right after I show the injection. Thank you. So what they do is they have you lie on your side. They do it right in the office. They go ahead, numb the area, usually use iodine or something like that to sterilize the area so that they don't expose that area to an infection, because we have bacteria and viruses all around us constantly, unlike, don't let me get on a tangent. Anyways, so they'll go ahead and they'll put that little needle down in the top of there and they'll just inject it. Usually it's a combination of lidocaine, which is a numbing agent, and then they'll use either dexamethasone or prednisone, which is a steroid, and that'll basically numb that area and hopefully get the inflammation down. And then you'll leave. That's basically an office visit, $500 or $600 or whatever. I mean, they make that simple, that quick. They could probably teach anybody how to do that in probably a half an hour. But so some exercises that you can do for if it's specifically bursitis of the hip and it's nothing else going on, first thing you want to do is stop crossing your legs. Okay? Make sure that you're not lying on this side when you're sleeping at night. Make sure you're lying on the other side with pillows between your knee. Those are the positional things you need to do. Now that bursitis, that iliotibial vein is part of that bursitis, and it's going to run down the side of that leg. And so we want to go ahead and unload that entire tendon. So you might want to have 2 or 3 pillows underneath that leg to put this tissue in a shortened rested position. Next thing you want to do is you want to heat the area. I'm going to put Big Bertha down here for a second. You want to heat the area, and you want to take either a dowel or a rolling pin and just gently roll up and down the side of this leg for a good 5 or 10 minutes. You want to heat it first for about 5 minutes or so, and then gently start the rolling pin. Just be mindful that when you go over this big bone, that you don't go over hard, because that bursa is very superficial. And so you don't want to roll over and, cause the thing to get more inflamed. That wouldn't make any sense. And so positional, heating, rolling pin. There's a taping technique you can do. I've shown, if you want to look in, probably my neck ones has it, and the shoulder has the tape itself. You're going to want to either use kinesio tape, which is the elastic-based tape, or Leuko tape that you can get online. You can get a whole roll of it for like $5 or $6. I have links in those videos that show. You can go and type Leuko, Leuko tape, and it'll come up. It's a brown thick tape, or kinesio, Kinesio tape, and you can go ahead. What you want to do is you want your leg to be in a rested position. We want to do a V pattern. You want to go down by the knee itself, and one strip comes up the side, and one strip comes up the front, and you bring like the letter V or Y, and then you bring a strip right through the middle to pull that IT band and that tissue in a rested short position. You wear it for 2 or 3 days. Make sure it doesn't get itchy or scratchy. Then obviously you want to take a nice hot shower to heat up the glue and then peel it back off. That's a good thing to put that tissue in a rested position. Oh, Dave's asking me another question again. I had the K-tape. Michael uses it for his knee. We are just old people. Ha ha ha. Oh, okay. Be mindful though is make sure that you have good skin integrity. Make sure when you use that Luco, you say, okay, the K-tape you'll be fine with because that doesn't have a strong adhesive to it. But you want to do 100% stretch on that. You put the one piece with no stretch, what we call an anchor, okay? Probably maybe an inch or so long. Lay that down with no stretch, and then give it 100% stretch. Lay that down, and then put an anchor point with no stretch at the top, and do that for the 3 pieces, and try and wear that for 2 or 3 days and see how that feels. And then obviously the biggest thing is icing the hip area as much as possible. That's the best I can give you. Stretches and strengthening, you want to only do that once the inflammation is calmed down and it doesn't hurt much anymore. Then you can go ahead and start the stretching and strengthening. In the clinic, what we would do is we do some ultrasound on top. We might do some iontophoresis with dexamethasone, which is a steroid, and we actually use an electrical current, DC current that is, to kind of push or repel the medication into the skin. Kind of like 2 negatives repelling each other, or negative and positives, kind of like magnets attract. And so we use what we call the ions. It's a little sciencey there a little bit. Throw some science at you. We use a negative charge and the negative ions that's in that medication to repel it and push it into the skin. Hi, Bonnie Rose. Bonnie Rose, thank you for coming. Like I say, anybody that I don't remember right off the top of my head, I will be checking this live stream just to make sure if I am a subscriber or not. If I'm not, I will be subscribing and I'll be watching part of your movie or show, whatever you want, how you want to describe it, and leaving a healthy comment for you. I'm doing well, Chris. Thank you so much for coming. I got 13 in the house right now. Thank you all for coming. It's beautiful. Go ahead, you guys connect if you want to. Oh, Chris is throwing a check out there. Come on, Chris. You know I can't take the check. Check mark's gonna look like it's a spam. Just do a heart, or yeah, we're connecting, we're friends, I'm at your house, I'm coming over, whatever type of slang you want to use or silly phrase. I try and make up a phrase every once in a while just to throw people off, so maybe they'll look at it quick and then they'll spot me. Especially when you get some of these live streams that are 60 and 70 people. It's like, they're not seeing your stuff. Thank you, Epic RV, Bonnie Rose. Oh, man. Who else have I got in this place? Oh, I still Larry is here. Our Epic RV. Dave is wondering about why his leg hurts when he gets up in the truck. Well, first of all, Dave, you probably want to get some runners on that truck if you have to lift your leg up that high, brother. Dave's awesome. I'm waiting for him to make some more content so I can watch some more of it. I know I keep busting. I read your stuff that you saw me busted on you. But, so let's talk about when you put your leg up into that truck. Now, if it's a high enough truck and you have to really throw your leg up in, if you have any arthritis on the, let's pull this back off. Let's see, does this little guy, oh, good, my little guy, his hip comes off too. I paid a little extra so his hip would come off. Some of these models you get, their hips and stuff don't come out, and some other stuff, they're kind of cheaply made. So, but anyways, let's go with Mini-Me right now. We're gonna put Big Bertha back up here. All right, so when we look at the actual socket here, and if Dave has any arthritis in the ball, more than likely it's in the socket area. And when he brings his leg up high enough, he hits that arthritic spot, and it gives him pain. Now, Dave, are you having any clicking with it at all, or are you just having like a pain in the groin area? I got someone watching from Singapore. Dang, in the house. Thank you for coming. Go ahead, and if you want to connect with others that are here, that's beautiful if they want to connect with you. There's no clicking, Dave says. Dave says no clicking. So it's not snapping psoasm, okay? More than likely, Dave, you probably got a little arthritis in that hip. Now, if it feels like it's not shooting down the leg at all or going up into the hip area, then it probably is just some arthritis in that hip area. And the best thing I would tell you to do is watch my video on Saturday, because I'm going to go over some treatments. I'm going to give you a little preview of what I'm going to talk about. I'm going to go over a TENS unit with you all on Saturday. I'm going to go over some different medications and creams that you can use, that you can buy at the store to help reduce that pain from osteoarthritis. I'm going to show you a few stretches that you can do. And when the pain is calmed down, some strengthening exercises. I mean, everybody already knows ice and heat. So I was trying to do some things that no one is kind of doing. So that's the thing. I'm just looking at my notes. That's the things that I'm going to go over on Saturday. Got 9 people still in the house. 7 loves out of the 13 that came, or 12. I guess I would count it as 1, something like that. So not bad. I didn't get any thumbs down yet. No thumbs down. That's always a good thing. And so that would be my best bet for you, Dave, right there, is that you're getting a little bit of hip osteoarthritis in there. Without knowing your medical history and anything like that, that would be my best logical guess with the information that's given to me and when you're having that pain. Do you notice, Dave, do you have less pain during the summertime with that same movement? My replaced hip is stronger than my other hip. Well, that's true. It can be, because if you're having any type of pain in that other hip, your muscles naturally will be, I should say, the strength of those muscles around the hip will be reduced, because the body's natural tendency is to slow down nerve conduction to muscles when there's pain. It's just a protective mechanism. And he says, no, it's always the same. Well, that's probably what it is, Dave. And it's probably good enough that even during the heated summer months, you're still having pain in that area. I would have you come and look at my video. I'll probably come out Saturday afternoon when I hopefully get enough time. I want to make a real in-depth one in regards to more, how would I say this? More after effects and stuff like that. I want to try and really see how far I can go with the software and stuff like that, to see how far my computer and internet service will let me push it before it kind of starts to freeze up. Because I notice when I start putting a lot of extra thrills, you know, the lighting, the sound, the animation, the graphics, I start really pumping that up. And all of a sudden, I start getting a lot of glitching and stuff, even when I lower the frames per second rate and stuff like that. So I was told to have that hip replaced, but put it off and have been losing weight. It's been less painful. That's right. I said earlier, if you weren't here, brother or sister, for every 1 pound you're overweight, it's 3 pounds of extra pressure on your hip. It's actually 4 pounds of pressure on your knee. So it's a 1-to-4 ratio at your knee, and it's a 1-to-3 ratio at your hip. So when you're overweight and you're having hip or knee pain, more than likely it's because you're overweight and you got to lose weight. So there's less pressure on your joints. It's awful, but that's the reality of it. I don't like it any better than you. Oh, man, Mama Alona saying, hey, Dave, old man. That's some love there for you, folks. Any questions, so anything else in regards to the hip? So we went over hip replacements, the different kinds of hip replacements and stuff. We went over some referral pain in the hip, clicking, labral tears. Oh, I could do, I have to do piriformis. Absolute McGregor, thanks for coming. Thanks for coming. Hey, did you get that video camera yet so we can start to see your actual, as you're doing the drawings, McGregor? I know that was one thing I asked you. I haven't got back to see if you've done it or not yet. All right, he's not telling me. So let's go into piriformis syndrome. That's another trash term. Now, I talked about this last week or the week before on my lives. I'll go over it quick. So piriformis essentially is it's the main external rotator muscle of your hip, which means it rotates your hip outwards. It kind of goes from underneath your sacrum, that's where it attaches at, and runs over and attaches to the hip so your hip can rotate outwards. Now you have your sciatic nerve that runs right where my finger's at. This part of your hip is called your sciatic notch. That's right. Your sciatic nerve is that big. It's a huge bundle of nerves. I remember when I dissected the human back at Mercy College years ago, and I said to the professor, at the time she was also a professor at Einstein University, smart lady, wonderful lady, very nice. Tough, but very sweet, very nice. And I said to her, what the heck is that? Is that a muscle? And she started chuckling. She probably never see this, and she'll probably never remember. But anyways, it was your sciatic nerve, and it runs through there. And that piriformis can come on the top of it, on the bottom of it, or every once in a while, that muscle group can actually split that nerve. And it's how you just grew. We're not cookie cut. We're not all the same way. That's right, Mama Alona. Well, it's not only an informative stream, but also it's also if you guys all want to connect too. I just didn't want to be another one of those people that just reads off people's statements and says, oh yeah, so-and-so wants to connect with her and so-and-so wants to connect with you. Come on, connect. I mean, okay. I mean, that's good for a while. After a while, it's kind of like, I mean, I want you guys hopefully either learn something, maybe reduce your pain, maybe ask a question. No question's a dumb question as far as I'm concerned. Maybe help a loved one, maybe help trivia night. Maybe this will help you with that. So that piriformis muscle, if it gets inflamed and irritated, it can pinch on that sciatic nerve and give you disc weakness, sciatica type symptoms, and it's really just coming from that muscle group. Excuse me, some people talk about stretching it. Some people talk about strengthening it. I say manage it by reducing the pain, shortening the tissue first. Do all the simple. Anybody want to go over the treatment for the piriformis? Go ahead, give me a yell out. All right, thanks for coming, our Epic RV Adventures. Thank you so much. I'll be seeing you, I'm sure, on your channel too. I try and come over there at least once a week and see how everybody's doing. Say hello to Mr. Turtle for me. All right, so the piriformis itself, that little butt pain that people can get, that muscle, what you want to do initially is make sure you're not sitting for prolonged periods with a wallet or something in your back pocket, because that can compress that nerve as it comes out where that muscle is, and it can give you some symptoms. And also it throws your hips off too. Your hip alignment can be off too. I think that's what I might talk about next week, is like hip rotations, SI joint pain. I think that's a good one. What do you guys think about that next week? That might be a good one. People talk about, I got SI dysfunction or SI pain, stuff like that. I might do that next week, depending on what everybody wants. But you want to first make sure that you have everything out of that side so that your hips are level, because when you sit, you technically should be sitting on these bones. If you're not and you're sitting slumped, you're actually sitting on your tailbone and you're gapping your lower spine, and you're causing a lot of stress to those joints in that lower back as well as the muscle groups when you don't sit upright and sit on your ischial bones, which is what these bones are called. Those are solid bones. The spine's not a solid bone unless it's fused. Oh, Lionel, that's all right. I'm sorry I didn't get to watch your live stream the other night. It was late. I wasn't feeling that good, and I had to go to the gym the next morning. I loved that bingo. Yeah, the ball that was thrown out. Oh, that was beautiful. How you had that thing shooting out at you. That was mesmerizing. I mean, it really was. I mean, I just stared. I didn't realize how much time went by. I'm like, and all of a sudden it was like 5 minutes. I'm like, oh God, I gotta go to bed. And I was just sitting there staring at that something keep shooting the ball out. All right, and so also the other thing you want to do is you want to gently either foam roll or a gentle ball and just gently roll across that piriformis muscle, because that muscle is running this way across your hips. So let's turn Big Bertha around here so maybe you can see a little bit better. Oh, sorry, that was loud. It's running across this diagonal way, and so you want to roll that foam roll or the ball. Don't lean all your way onto it, because you're not helping yourself. You're basically crushing that tissue against the nerve, and it could give you some shooting pain all of a sudden, or heaven forbid, numbness. You got to roll that nice and easy for maybe 3 to 5 minutes, and then throw some ice or heat on it. You might want to come in and do a gentle come across. You can do this in sitting or lying down, what we call the gentle piriformis stretch in this position. You're not twisting your back. It's just a knee to the shoulder. Do something nice, just a gentle pull. And then you can go ahead and look on my playlist. It goes over a couple other stretches and strengthening exercises for the hip and piriformis syndrome. But those are the real tidbits that you should take away. And that should at least get you on the way to reducing a lot of your pain. Extra Step CEO coming in. Thank you so much. Hello, Extra Step. Thanks for coming by. We're going over the hip. We went over hip replacements. We went over arthritis of the hip. We went over snapping syndrome of the hip. We just went over piriformis. We went over some referral symptoms going down the side of the hip into the iliotibial band or the IT band along the side. Go ahead and give a thumbs up. Oh, I'd love it. Thumbs up or thumbs down, one or the other. That way I know that you at least said, you know, if you're angry, get the thumbs down. If you're somewhat happy, give me a thumbs up. Oh, Larry 5200, you're awesome, sir. All right, so any questions so far with any of that? Oh, thank you, Lionel. That's very nice of you. Thank you so much. Yeah, we talked about that whole anterior lethesis is basically what that $50 word, what you're describing there, where a vertebrae. So let me go ahead and let's say I pulled a vertebrae out and I blew it up, and this is what you would see. You got your disc, you have the vertebrae above, which is what this bone is. You have a vertebrae below, so it kind of looks something like that. So what he's referring to is that he's got shifting forwards on the spine. So you can see how much stress that disc and everything's taken, and how all the joints in the back, you can get a couple of different kinds of fractures back there. Pars defect is one of them. You can get Scotty dog fracture. There's, I'm not a radiologist. I'm a physical therapist, so I know some of the terms of what happens when you have that much translation, you can see how this is the spinal cord, okay? The spinal cord ends about L1, L2, so it's up much higher. After that point, it's called cauda equina, which means, and that's Latin term, it means horse's tail if you're to put it in English. Which means that the spinal cord ends and you just have these nerve endings off that spinal cord. And so you can get a lot of problems, whether it's the spinal cord or whether it's the peripheral nerves, when you have that much shearing force going forwards on one vertebrae on the other. I mean, that's a lot of pain. The ligaments get real thick. The disc just gets crushed. The pain that you're in, brother, it's just got to be excruciating. My Scotty dog was euthanized. Oh, God. Anyways, the term Scotty dog, I like that. I'm sure he knows what I'm talking about. That was cute. That was funny. For anybody else that doesn't know, if you look on an X-ray, and if you typed in Scotty dog fracture, if the X-ray itself actually looks like a Scottish dog, and so that's where the term Scottish dog fracture or Scottish dog fracture looks like, or where it came from, is because that's what it actually looks like on an X-ray, on a lateral view X-ray, that is. So you see the X-ray from a side view versus a posterior view, or from an anterior view. When they do an X-ray and they want to really look at what's going on, they usually do at least two viewpoints. So they might do a side and back or side and front. They need to see a couple, kind of give you a broader picture of what's going on. Oh, thank you so much for sharing me out. That's very sweet. I know Essence shared me out earlier. I realize you guys are on the other side of the planet, and it's probably, I think she said she was like 6 or 7 hours ahead. So I'm 7:30 Eastern Standard Time, 8, 9, 10, 11, 12, 1. It's like 1, 2 o'clock in the morning. I got to give you guys credit. Thank you. And I see also Essence earlier, she was having like YouTube issues disconnecting or whatever. So I hope you guys have fixed it on your side of the planet. Oh, I got Deborah. I didn't see her in here. Deborah Cash by Faith. I'm sorry, Deborah. I didn't see you in here. Thanks for coming by. I got exits. I got knife right in the right cheek, type pain straight from down of both legs. Feels on both. Yeah. This guy needs to have surgery. Is what he needs to have. I've been a physical therapist for a long time, and I'm telling you, I can't fix you. Yeah, you probably need to see a really good surgeon, whether you do it or not. But yeah, I got to give you credit. You've put up with a lot of pain. I'm sure if they fixed that much translation, you probably would feel immediately reduced pain because you've been in it for so long, and it's so much of a forceful translation forwards. Honey and Josh, I know you guys are here. I saw you here earlier. Go ahead and connect. If you guys want to connect to each other, that's beautiful. Thank you. Go right ahead. So we talked about the hip pretty good. We talked about the sitting positions. We talked about piriformis. Talked about labral tears, snapping hip, arthritis, hip replacements, IT band syndrome. Talked about a lot so far. Oh, how did I forget? You can have just tendonitis of your hip flexors. I get that sometimes. Sometimes it ends up being a labral tear. Sometimes even with a labral tear, it doesn't needs to be surgery either. Not all tears need to be fixed. You could have had them for years and been asymptomatic, which means no symptoms until the thing got inflamed for some reason. But you have, like I said before, that one main muscle that comes down from the side of the spine. The other muscle inside the hip, they too make up that main hip flexor muscle. There's also another muscle on the front side here called your tensor fascia lata. It's a small one. It's one of your main hip flexor muscles. Runs from here to the hip itself. And that area in the front can get really inflamed and irritated. You know, people will go and start doing this. They'll start digging their thumb into the front side of their hip. And basically what they're doing is displacing the weight off of the hip or off of those tendons and moving it somewhere else. Now, there's something, now that technique's used in the elbow, like an elbow strap, what we call a strain counter strain strap, or in the knee, you might get a patellar tendon strap across the knee, the tendon, and that what that helps to do is displaces or moves the pressure away from that inflamed tendon. I need some more drink. I'm talking a lot. Since 1979, this brother's had this problem. I'd be curious, Lionel. Every time I hear Lionel, I think of one thing. Now I'm much younger, so there was this cartoon called the Thundercats. I grew up with this cartoon called the Thundercats, with this sword that the guy would say, "Thunder, thunder, thunder, Thundercats roar," and the sword would open up and his eye would pop out, and the main character's name was called Lionel. Now, people probably remember Lionel Trains. I remember the cartoon. So every time I see or see that name, that's the first thing I think of. Yeah, you think trains, I think Thundercats. That's true. Keep loose and flexible does take a lot of the stress off of those areas. I'd be curious, before I started on my tangent with the cartoon, Lionel, is if you don't have any natural fusion that's happened because you've had this for so long. Have you had a recent x-ray to see if any of the vertebrae above, below, or if the sacrum itself or the SI joint is actually naturally fused itself? Oh, I lost a lot of people. We're down to 3. They all left me. Okay, so any more questions? That's what the surgeon said at 29 years old. Yeah, okay. Yeah, and that was a few years ago, right? Okay, so this hip right here is a basic natural average size of an adult hip. No, not every hip, but average size. The hip itself has got multiple parts to it. It's got this part here, the top. This is called the iliac crest. It's got this bump in the front. It's called the ASIS, or anterior superior iliac spine. And it's got the backside, an inferior iliac spine. Posterior, excuse me. And then the inferior one's down here. Boy, I messed that one up. Now, as we age, like I said last week, the tendons all attached to these things, like the quadricep muscles and stuff like that, they all start to pull on that and make these protuberances larger on some people, all right, depending on how fast they grow. And you can have some irritation with those tendons over time. And that's where some of that iliopsoas and snapping issue comes from. Any long tendon in our body can get inflamed, and around this area, that snapping hip, is where it's going to occur at, and it's going to start to strum over some of these bony prominences that you have. All right, so we're going to rotate to the back here for a second, and we're going to pull on up to this little joint here on either side. This orange thing is called their sacrum. Normally, it's got no discs in it. Now, you can get a congenital disc, in the SI joint. Like a disc in your spine, you can have a disc in your SI joint, and that can cause some problems. It probably will naturally ossify and fuse over time, but that could be giving you some problems too. So you wouldn't know unless you had an MRI or an X-ray to see whether you had that or not. So this joint right here is called your SI joint. The sacrum, S, and the I is the ilium. So that's the SI joint. So when you move, when you flex forwards like this, your L5 joint moves forwards. Your sacrum goes in the opposite direction. So when you sit, you are putting a ton of stress on that joint if you're not sitting on your ischial bones. If you're sitting on your tailbone, you're sitting like this, like I see the letter C, you're putting an extreme amount of stress on that L5-S1 area. Naturally, just because when you sit or when you flex forwards, they separate one another. One goes one way, then the joint goes the opposite direction. And the same way holds true, okay? When you extend your back, your sacrum goes in the opposite direction. Now, these fused bones are fine. They're solid, unless you have a disc, and that can cause some problems. At the end, you have the tailbone, or what we call the coccyx in the in the medical community. And if you fall and break that coccyx or tailbone, that's it. They're not going to screw it back together. You're going to have a lot of pain. You're probably going to sit on a donut for a while because you don't want to put any pressure on that tailbone. Look at this guy's tailbone's broken too. Came that way, folks. Oh, hey, Big Heck. Yes, I'm sure. Anybody that comes in my live stream, please put a thumbs up or thumbs down. Anybody that I haven't subscribed to, I'll be looking at the end and subscribing, watching your video, and leaving a wonderful comment for you, okay? Try not doing any finger pointing just because they're going to look at that as spam. Thank you, Big Hack. So we've gone over a lot today about the hip. I'm going into the SI joint, or the sacrum, the solid bone in your hip, and this part of the pelvis, or what we think of as the hip. People will say, "Oh, this is my hip." Your hip is actually here. That's the ball and socket. This is actually your pelvis, and we get real fancy and call them. You have your innominate. Okay, you have your left and right, but we don't have to worry about that at all. So when we talk about an SI joint problem or SI joint pain, they might do injections. And so sometimes the pain's really coming from the L5-S1 joint on the side. So this little facet joint in here can get inflamed, or the disc itself, or the body of the vertebrae can get irritated and cause pain and come down into the SI joint. I mean, if you fell down a bunch of steps, or if you landed on that side of the hip, yes, you probably have an SI joint problem. But we would test you and look at you to make sure that when you lie flat, we're looking to see that your hips are level with one another. We look at these bones right here, the ASIS, which I talked about earlier. We're going to have your legs out straight and make sure your legs are equal, that the bones in the bottom of your feet, what we call the medial malleolus, when we look at them, we make sure they're equal. If they're not, then we need to make sure that you don't truly have a bone-leg length discrepancy or some sort of upshift on your hips, or what I'm going to talk about a little bit today, but probably for the next week, is a rotation. This guy's fused pretty good, so he's not going to rotate, but your hips rotate when we walk. And so you can go ahead and have an SI joint dysfunction, it's called, and we might need to do some assessment and therapy on that. It takes a lot more detail to assess, and so that's a whole other program to talk about. The sacrum and how the sacrum rotates. We have nutation, counter-nutation of the sacrum. We have all kinds of crazy stuff when it comes to the pelvis and the SI joint. But when you go and see the doctor and they've kind of looked at your x-rays on your hip and your lower back, They've kind of rolled out piriformis syndrome and all this other stuff. They're gonna, SI joint dysfunction is almost what I call the rule out. They rule everything out, or the absence of everything else, and they're gonna say, yeah, okay, let's go ahead and treat the SI joint with some injections and see if your pain goes away. They'll send you to either a anesthesiologist, or sometimes I guess you could have a regular ortho or neuro do it, but usually it's usually one of those. Excuse me, follow my words here for a second. It's usually the anesthesiologist that does that. So they'll go ahead and inject that SI joint area, numb it up, have you come back in 4 or 6 weeks to see how you do. It seems like your pain went away. You might go ahead and inject the area again and see if your symptoms stay resolved. So that kind of gives them an idea that it's coming. And then they'll obviously send you for physical therapy, and we'll go ahead and look at what's going on, whether it's positional, whether it's a leg length discrepancy, or whether you have a hip that's out of whack, as you could say it, generally saying that one pelvis is rotated forward while the other pelvis is tilted back, and you're having a lot of stress in that joint because they're kind of stuck in one spot. And so that's the basics of the real basics, I should say, in a general review of a type of SI joint issue. All right, anybody got any more questions so far? I don't know why I yelled that. It isn't like you guys can hear me if I yell louder. Hey, Big Heck, you still here? When we talk about the back, I have a huge playlist on disc versus spinal stenosis versus postural dysfunction. I go over some treatment techniques that you can do at home, and a lot of times that will reduce a lot of your problems. Okay, yeah. If you as you age, let's say you're like Lionel's age, Lionel's like 25 plus, your disc actually starts to ossify as you age. It becomes harder. And so your likelihood of getting a herniation or rupture or fragmentation of the disc becomes a lot less as you age. But then stenosis kicks in, which is narrowing of the canal as we age, where that nerve comes through. And so that canal right here that I'm talking about, where that peripheral nerve comes through down below, all right, and then obviously this guy shows a little disc on this, a little disc bulge on the side. So what we're talking about is how I can get that guy to blow out a little bit. So if you get that little baby blowing out and hitting that nerve, you see that? Oh yeah, let's show that. Let's show that. Let's show that. Does it show up good? All right. So that blowing out like that, realizing that that disc comes in and comes out, comes in and comes out. If you can reduce the stress on that joint by proper sitting and some of the other techniques I show in the disc video, as well as the spinal stenosis video, you can calm down the inflammation that's probably causing more of your problem than the disc. The disc is going to come in and out. After a while, the disc can scar up, and scar tissue will hold that in place. Band on the Run. Maybe a guy called the Beatles. Yeah, oh yeah, Before the Wings. That's right. Good old Paul. I love his music. Is so good. Even today, I mean, that's how good the music is. That, here it is 40, 50 years later, and you can listen to some of Paul's stuff and even John's stuff, and it's just as current today as it was then. You can't say that for like probably 25 or 50% of the stuff that's out there, hits today ain't going to be something you'd even want to play 50 years from now. It's not going to be current at all. That's right. It's timeless. Anesthesiologist. That's right. Thank you, Lionel. Yeah. I was trying to think of, there's another type of physician that is like a rehab doctor. You don't see them very often, but they'll go ahead and do injections too. And I was trying to remember their name at the same time. And I was having basically a brain fart. Even happens to the good old average Joe. The foam roller to the lower back, I've seen it done before. If you're young enough and we're not dealing with like, if you're having any type of significant arthritis in that lower back, and you can have that early on. You can be in your late 20s and mid to late 20s and start to have arthritis in your lower spine, and then progressing as time goes on. The degenerative disc, all right, is a normal aging process of the spine. That's normal. It's normally asymptomatic, means you have no symptoms of the disc. That's not a disease. So if it's not too bad, the only thing I get afraid of is when you start rolling over something is you start arching your back a lot more, and it starts to place this, what we call facet joint, where my finger's at, and it can get irritated if you overextend too much. Okay? And so that can really mess things up. So you got to be mindful of that. So if you're going to roll carefully over the area. I would say stick to a much smaller roller first. The bigger roller you have, the more your spine has to arch over it. The smaller the roller you have, the less your body has to roll over it. So I would start with a very thin roller, foam roll, and then work my way up to larger ones over probably a 3 or 4 week period. Do not go big. If you go big early and inflame that facet joint, you're going to wish you didn't. Yeah, right, facet joint, woof, woof. Well, if you're talking about diameter, 10-inch or 12-inch diameter, yeah, I'd say that's probably pretty good. And I would only do it for probably 2 or 3 minutes. And make sure that you got some of your weight displacing through your arms and through your legs. Don't put all your weight through that spine, because a lot of the, I don't know how athletic you are, but you need a lot of core stability. The multifidus muscle I talked about probably, I don't know, 6 or 7 videos ago. I have it in there. Talks about that's a huge muscle of your spine. It's a major stabilizer of your back, as well as your abdominals. Those two things work in conjunction with each other, and they need to be fairly strong and stable for you to be able to roll over a uneven and a movable surface, because your body's like, whoa, what's going on? If you ain't got a good trunk and core stability, you're going to put excessive stress on that joint, and that joint can also get inflamed too, because you don't have enough stability around the joint while you're trying to roll it at the same time. Oh, you're welcome, Big Hack. That'll at least start you on the right path. If you have any further questions or whatever, you can go ahead and look at my, a couple playlists under the back, and you can just go ahead If you want to speed through just to see what part you want, I could care. I'd love you to watch the whole thing, but it's about most of my content that talks about treatment wise is usually about halfway through, especially the newer stuff I've made over the last probably 5 or 10 videos. I try and throw some more comedy into it so no one is bored. And hopefully they'll watch my stuff longer because it's a little funny on top of giving good content, hopefully at the same time. Okay. So there's this other thing that I don't talk about very often because it gets things confusing, but there's this thing called the myofascial system in our body. And essentially it lines our entire body, and anytime you can get any kind of what we call myofascial pain, it can also refer symptoms because it lines the entire the body. And so you can get some weird myofascial pain along the top of the crest of the hip. It's very bony up here on some people. Some people it's not. They have a lot of fat in the way. Don't be a hater, be a participator if I said it. So, and that area can get very tender. So when you're rolling, that roller that I talked about earlier on the side of the thigh, the IT band, be careful over the top because you can get that myofascial system inflamed. Just like Big Hack there when he talks about his lower back. You got some big butt muscles, and that's big and meaty. You got some big back muscles, that's big and meaty. That can take up a lot of that excessive pressure. But across the iliac crest, be mindful because there's a lot of myofascial system there. And if you get that thing irritated, it can give you some referral pain all over. Sometimes if people are fairly big and they got a belt and they got that belt really tight, and that's really starting to crush some of that myofascial or some of those tiny nerves that come over the top, it can give you some weird numbness across the iliac crest. And all that is because you're actually pinching or squeezing those nerve endings. So you can get it that way, or if you start rolling over it too hard, you can get it that way also. This boy is 6'3". This boy goes 240. This guy is serious. Big Hack is big dog. I mean, this boy, I'm 5'10". I weight lifts. I go about $190, $185. I'm probably about 100. I've been trying to get down to 180, but the more I work out, it just ain't happening. It's just my build at this point. I weigh about 190 pounds. My waist size is about 33 at this point, so I've trimmed down a bit. So, but I'm only 5'10". This boy weighs 6'3". This guy goes 240 pounds. This is a serious man. This guy's big. And so, yes, you could do a larger foam roll if you wanted to. I would probably do a smaller one for maybe 2 or 3 times just to get the tissue to accommodate to that pressure and see how you feel. Delayed onset muscle soreness, DOMS for short. Everybody talks about it in the fitness world like there's some sort of educated person. Please, you can get that information in 5 seconds anywhere. That's basically you want to be sore no more than 2 days. If you're sore more than 2 days, then it was too hard for you. So take that also in context too when you do that foam roll. You want to go a little bit bigger, you should be sore the more than 2 days. If you are, then stick where you're at or even back down to a smaller surface area. My gosh, Lionel, you are Lord of the Thundercats. 6 foot, 340 pounds. You are a big hoss. You are the nose guard. I'm the guy behind you, and you're just pushing that line, and I'm just going by, man. I'm just going by as you're pushing everybody away. You're welcome, Big Hack. All right, does anybody have any more questions before I move on? I'm going to do a few more minutes, and then I'm going to go ahead and let you all go unless you have more questions. At 42, he dropped 140 pounds. That's some serious, he dieted hard. You know, way you lose that weight by just walking. I think it's 75. I wish I had to talk to a registered dietitian more so I could get some more statistics. I think it's 75 or 78% of losing weight is all diet or eating healthy. Diet's a bad word. Eating healthy, changing your lifestyle, whatever you want to call it. It's all that. You know, exercise is a very small part of losing that kind of weight or losing weight in general. Oh yeah, he's a big boy. Yeah. Don't mess with the lion. Hopefully his back hurts enough that he can't catch me when I'm running away from him. All right, you guys have any more questions? Oh yeah. You can do it. You can do it. Definitely, exactly what you're saying, Lionel. Exactly. It ain't easy when I got McDonald's down the street. I got Arby's here. I got Chick-fil-A there. Oh man, I have to tell myself and know a lot just to stay the size that I'm at. Oh, Scratch Queen 407. I'm doing all right. Thanks for coming by. You see anybody you like, go ahead and connect. I talked about a lot tonight. Talked about hip replacements, hip arthritis. Talked about snapping hip syndrome. Started a little bit about the SI joint that I think I'm going to finish up maybe next week with. Bye, Nikki. Thanks for coming by. I want to say to you guys all, thanks for coming. All right, we're going to go ahead and finish up tonight. And Scully and I, we're going to go ahead and close out by saying, we want you to look up and keep smiling. All right, see you all later.